Hi, my name is Martin Bisson, and today the title of my presentation is 3D Visualization Tool for Minimally Invasive Discectomy Assistance. I will first give a brief introduction to put you in the context of minimally invasive surgeries. Then I'll present the materials and methods we use to develop our system. I'll present the results we obtained and conclude by making recommendations for future work. So, minimally invasive surgeries, as opposed to conventional open surgeries, are done by performing small incisions through which the surgical instruments and the endoscopic camera is inserted inside the body. They have several known benefits, such as reduced blood loss, less post-surgery pain, less recovery time, and less overall treatment cost. However, they bring a new set of challenges for the surgeons. They have to work with relatively long instruments, which results in limited dexterity and tactile feedback. The surgical site is viewed indirectly through a monitor and an endoscopic camera, which brings a loss of depth perception because the view is monocular and the lens is so close to the surgical site that there are very few depth cues. This proximity also brings a loss of global perception of the shape of the whole spine, and all those drawbacks make those surgeries very difficult to learn. Je saute cette étape-là parce que j'ai pas le temps. So in order to help the surgeons with those difficult procedures, we propose an augmented reality system that will present to the surgeon an integrated image that will combine the endoscopic image and information coming from a preoperative 3D model that would have been registered with those images. Therefore, the surgeon will have more information than the information present only in the endoscopic images. So in order to realize such a system, well, first in our lab we use a 45-degree angled view endoscope, which is composed of a lens system in a cylinder tube that is plugged to the camera head through a circular attachment, which allows a relative rotation between the lens system and the camera head. This rotation helps the surgeon explore the interior of the body just by making this rotation a little bit like you would do with a periscope. We also use the micron tracking system, which is able to track in real time the position and orientation of special patterns, example of which you can see here. So we fix one of these special markers on the tube and another one on the camera head. Then we have our calibration method, which allows us to find different sets of parameters that models the camera, the endoscopic camera. These parameters are the intrinsic parameters, which are basically the focal length and optical center. The extrinsic parameters, which is basically the position and orientation of the camera in 3D. And the finding of this calibration part is usually known as hand-eye calibration. We also calibrate the distortion parameters, which are needed to take into account the deformation that is induced by imperfect lenses. And we use a set of rotation parameters to take into account the relative rotation between the scope, the tube scope, and the camera head. Our offline calibration method that is done before the surgery is basically imaging this simple calibration pattern. Then our method extracts automatically the corner of the grids that are needed for the calibration. Two sets of views have to be taken. One set is done by moving the scope between the views without rotating the camera head, and the second one is obtained in the same way, except there is a relative rotation between the camera head and the tube. These sets are sufficient for our method to obtain all the needed parameters. when the surgeon moves the endoscope, obviously the extrinsic parameter will need to be updated. This is done by the use of the tracking system that is able to track the markers on the scope. But some operations, such as zoom change or focus adjustment, will modify the intrinsic parameters. We can still update them using Girard self-calibration method. So for the results, we computed the reprojection error, which is illustrated here. It averaged 21 pixels, but it's very jittery. And as we can see here, it's not randomly distributed in every direction. It's oriented, and it's done, and it's caused mainly by the jitter and imprecision of the tracking system. As a result, we also have the augmented views that can be created by the merging of the preoperative model and the endoscopic image. We've done two types of views. The augmented reality views are done by taking the reality, which is the endoscopic image, and augmented it with additional information such as projected virtual models or distance information. But we also created augmented virtuality views, in which virtual scenes are augmented by adding the endoscopic image at the right place. This allows us to generate views from a different virtual point of view, so that the surgeon can observe the surgical site from a different point of view, not accessible by the endoscopic camera. So in conclusion, we developed a fast and simple offline calibration method with fully automatic segmentation, which minimizes the need for user interaction. We update our model using the tracking system for the extrinsic parameters and a self-calibration method for the intrinsic parameters. We also developed visualizations of the merged information. We use the augmented reality views and augmented virtuality views. There's still work that needs to be done. For the registration, there's still work that needs to be done. In the short term, we'll use a single X-ray that will be taken before the surgery in order to register the 3D models with the actual patients. But in the long term, we will use a calibrated ultrasound probe to update the model. This will eliminate the need for X-ray and will permit the update of the shape of the surgery if it changes during the actual surgery. The tracking system also needs to be worked on in order to improve accuracy and robustness. We might need to add different multiple binocular cameras to improve robustness and accuracy, or evaluate maybe another tracking system. And there's also validation that needs to be done. We need to evaluate the efficiency improvement that result from the use of our system to perform different surgical tasks. So that's it for me. Do you have any questions?